Chapter 64 is in your Iggy Volume 2 book on pages 1556 through 1581. In this chapter, we will cover diseases that affect the male urinary and reproductive systems and the nurse's role in caring for these patients. This is a quick review of the male anatomy. As you read through this chapter, you'll see that a lot of the diseases we're focusing on revolve around the prostate gland, which is just beneath the bladder, and how dysfunction or issues with the prostate can affect the male urinary system. So we'll talk about BPH, prostate cancer, and we will also discuss testicular cancer and erectile dysfunction. When assessing male patients for reproductive system conditions, history taking is an important aspect of the exam. Several tools exist to aid in these assessments. If you look on page 1559 in your Iggy book, you will find the International Prostate Symptom Score. This questionnaire asks about the most common symptoms associated with prostate enlargement and gives a score to determine the severity. If you are not using the questionnaire, you want to ask about the patient's urinary elimination patterns, any recent changes in those patterns, urinary frequency or urgency, nocturia, which is frequent urination at night, so how many times are they getting it up at night to go urinate, difficulty starting or continuing urination, a weak stream, incomplete bladder emptying, straining to urinate, and leaking or dribbling. Digital rectal exams are also performed. Since the prostate is so close to the rectal wall, it is easily palpated by the healthcare provider. Through palpation, they can assess for the size and consistency of the prostate. In BPH, the prostate is uniform, elastic, and non-tender, while in prostate cancer, it will feel like a stony, hard nodule. The healthcare provider may also massage the prostate to obtain a fluid sample to rule out inflammation caused by prostate infection, also known as prostatitis. Testicular examination aids in the identification of testicular cancer. We should be instructing our patients how to perform these self-examinations and perform them monthly to help with early detection. On page 1573, you will find the steps for performing a testicular exam. Prostate-specific antigen, or PSA, is a protein produced by the prostate. High levels of PSA in the blood can indicate prostate cancer, BPH, or prostatitis. Ultrasounds may be ordered for several reasons, including a bladder ultrasound to determine residual urine, or a transrectal ultrasound to view the prostate and surrounding structures. BPH is the enlargement of the prostate gland caused by aging and an increase in the hormone dihydrotestosterone, which results in an abnormal growth of tissue in the prostate gland called hyperplasia. The enlargement of the prostate causes it to extend upward into the bladder, causing bladder outlet obstructions, which leads to the urinary signs and symptoms that patients report. The first sign that a patient may complain of with BPH is a decrease in force of the urine stream, and as the prostate gets larger, the symptoms worsen, leading to things like chronic urinary retention, overflow urinary incontinence or leaking, frequency, urgency, straining, frequent UTIs, and if this condition is left untreated, chronic kidney disease can develop in these patients. If you look at the anatomy of where the prostate lies and see that it is basically wrapped around the urethra, so as it enlarges, it's compressing on that urethra, causing this urine to get backed up. So this urine is backed up, and it can back up into the kidneys, causing infections and kidney disease. But also, with the bladder remaining full for so long, it weakens these bladder muscles. This slide reviews the common signs and symptoms for BPH. I do want to point out that hematuria is noted with patients who have an infection secondary to BPH, especially in older men. This slide lists out common labs that may be ordered on these patients. Most of these labs listed assess for complications from the conditions like BPH, prostate cancer, or prostatitis, but the PSA measurement is the only one that specifically helps in diagnosing these conditions because the PSA is only produced by the prostate, and high levels of PSA in the blood indicates an enlarged prostate. The urinalysis and urine culture is used for detection of UTIs. The CBC is used to determine if any systemic infections have developed. It can also check for anemias from hematuria. The BUN and creatinine levels are checked to determine kidney function and see if any chronic kidney disease has developed. Other diagnostic studies include the transrectal ultrasound mentioned earlier. You can also have a cystoscope done to visualize the bladder and the urethra. The patient may also have a transabdominal ultrasound or tissue biopsies taken. BPH treatment can vary depending on the severity of the condition. Treatment can range from careful monitoring to surgery. Some non-surgical management include behavioral modifications that patients can make. We should be teaching these patients to avoid drinking large amounts of fluid in a short amount of time, especially before going out or at bedtime. They should also limit caffeine and alcohol consumption, as these have a diuretic effect. Patients should also speak with their healthcare provider about drugs that can cause urinary retention. Examples would be anticholinergics, antihistamines, antipsychotics, and muscle relaxants. They need to ensure that they are not on these medications and they are not prescribed in the future. You can also instruct them that frequent sexual intercourse will reduce prostate fluid buildup. Drug therapy for BPH. There are several categories. If you look on page 1561 on your textbook, you'll find a table that describes each one. Two of the most common being 5-alpha reductase inhibitors and alpha-1 adrenergic antagonists. These are also called alpha blockers. Physicians often prescribe one of each category to work together for the best results in these patients. 5-alpha reductase inhibitors work by lowering the dihydrotestosterone hormone. By decreasing these hormone levels, it will shrink the prostate and prevent further growth. An important fact about these medications is they are teratogenic, so patients should be educated to store these drugs away from pregnant women or women who may become pregnant. An example of this category would be finasteride or Proscar. The next category is alpha blocking agents. An example of this category is tamsulosin or Flomax. These alpha blocking agents work by relaxing the smooth muscle in the bladder neck, making it easier for the patient to urinate. If conservative management and drug therapy are unsuccessful in relieving urinary symptoms, physicians and their patients may turn to surgical procedures. There are several different surgical procedures, some less invasive than the others. Most of them involve removing part or all of the prostate gland. For years, the gold standard was the transurethral resection of the prostate, or TURP procedure. It's the most common treatment that you'll see in the hospital. An instrument is inserted into the urethra to the prostate, and then excess gland is removed with electrical cutting loops. There's no incision. The patient usually stays overnight. They will have a catheter, a 3-way Foley, with continuous bladder irrigation going. I will show that in the next slide. What's now becoming standard practice is the new procedure called the holmium laser enucleation of the prostate. It uses a laser to remove the obstruction tissue and then pushes the tissue into the bladder for removal. This procedure has little blood loss, is safe for patients that take blood thinners, and will probably replace the TURP procedure once that is phased out. The images below show 2 different procedures to remove excess prostate tissue. The picture on top is the TURP procedure, where an instrument is inserted through the urethra to go in and remove that excess tissue in the prostate. Whereas the picture on the bottom shows a retropubic or retrovesicular prostatectomy. In that procedure, the surgeon is making an abdominal incision and going in and manually removing the excess tissue. Continuous bladder irrigation is an important aspect of postoperative care of a patient who has had a TURP. So after these patients come back from surgery, they're going to have a 3-way Foley in place, hooked to CBI. You're going to have an irrigation solution going, and then you'll have the drainage bag attached to a Foley. The output after surgery will be bloody. You may observe some small clots as well. We want to keep the flow going with this irrigation solution. Make sure that it never runs dry. Monitor the color and consistency of the urine output. Make sure the tubing is frequently checked for kinks or any obstructions. Monitor for decreased output, which may indicate a clot. Remind patients that because the catheter balloon is large with these procedures, that they will feel the urge to void and that this is a normal sensation. However, advise them not to void around the catheter, as it can cause the bladder muscles to contract and cause spasms. If a clot is suspected, manual irrigation may be required. Check with your healthcare provider to see what the protocol is for that facility. Review box 64.1 on page 1564 for more information about monitoring patients receiving CBI. You should also be monitoring input and output for CBI. Whatever goes in, it has to come out. So when you're calculating urinary output, you want to keep a running track of how many milliliters of solution you're giving to the patient. Most facilities have a paper where you document this throughout your shift. To calculate this, you're going to take the total of urinary output and subtract the amount of irrigation solution that you gave the patient. This number will give you the amount of true urine output that the patient had. Below is a picture of a CBI setup. So you have your 3-way Foley, a pretty large balloon that would cause patients some discomfort. You have your balloon inflation port, the urinary drainage bag, and the irrigation port. And the roller clamp here is where you're going to control the flow of the CBI. Discharge teaching for these patients includes telling them that they may pass clots and that this is a normal finding. Encourage them to increase fluid intake. Teach them that their sexual function should not be affected, however they may experience what's called retrograde ejaculation. This is where the semen flows backwards into the bladder so that only a small amount will be released from the penis. This is not harmful, but it may affect fertility. Depending on where the procedure is done, patients may go home without a catheter or with a catheter still in place. If they still have a catheter in place, be sure to teach them proper catheter care. Instruct them not to take a bath or swim, and teach them ways to prevent urinary tract infections while the catheter is in place. Instruct them that they may have a temporary loss of control with urination or dribbling, and that these issues usually resolve on their own. Prostate cancer is the most common invasive cancer among men in the United States. Symptoms are often not experienced by the patient. The first symptoms usually have to do with the bladder neck being obstructed, so the patient will express problems urinating. Contributing factors to developing prostate cancer include a diet high in animal fat, viruses, family history, vitamin D and E deficiencies. Patients can reduce their risk for prostate cancer. Encourage patients to increase fruit and vegetable intake, reduce animal fats such as red meat, eat more fish because they contain healthy omega-3 fatty acids. Also encourage men 50 and older to have annual digital rectal exams. When assessing a patient for prostate cancer, you want to take a thorough history assessing the patient's age, ethnicity, and family history. Ask about their diet. Ask about any symptoms they've had recently or any problems urinating. Ask about current medications that could affect voiding. And take a sexual history for recent changes in their sexuality, including low libido or function. Ask about current or previous STIs, penile discharge or scrotal pain or swelling, and ask about pain during intercourse. You want to prepare the patient to have a digital rectal exam, a PSA drawn. You want to draw this PSA before the DRE because it may cause a false positive reading. This picture shows prostate cancer. When a physician is performing the digital rectal exam, they're feeling on the prostate for a stony hard nodule with irregularities or indurations. These are the surgical options for treating prostate cancer. Each surgery is a radical prostatectomy, just performed in a different way. These surgeries remove the prostate and seminal vesicles. The surgery is guaranteed to cause impotence, and 5 to 10% of patients will experience incontinence postoperatively. Bilateral orchiectomies are also performed. This involves removal of both testicles. It is not a cure for the prostate cancer, it's simply a palliative treatment to prevent spread or future cancers. You want to monitor for complications such as urinary incontinence and erectile dysfunction. Patients may benefit from erectile dysfunction drugs such as sildenafil. Post-op care of radical prostatectomies. These are pretty similar to all surgery patients. We want to get them up and moving as early as possible. We're going to monitor their I's and O's, provide them with laxatives and stool softeners. The antispasmodic is to prevent bladder spasms and help control patients' pain. They will have a catheter for a little bit. If they had a lap procedure, it'll be for 1 to 2 days. However, if they had open surgery, it may be up to a week or longer. If you look on page 1571 for box 64.2, it goes into greater detail for caring for these patients. Non-surgical options for prostate cancer can include radiation, hormonal therapy, chemotherapy, or complementary and alternative therapies. Radiation therapy may be external or internal, and it can be curative or it can be a part of a treatment regimen in combination with these other options. Testicular cancer is uncommon. However, it is the most common cancer in men 20 to 35 years old. With early detection, it is very treatable, which is why it is important to teach self-examination. Tumors are classified. They are either germinal or non-germinal. Germinal tumors develop from sperm-producing cells of the testes, while non-germinal tumors develop from the hormone-producing tissues of the testicles. They rarely spread beyond the testicles. A small tumor metastasizes and tend to be resistant to chemo and radiation. Secondary to testicular cancer are those cancers that metastasize to the testicles from other organs, with lymphoma being the most common one. Cancer can spread from the prostate, lung, skin, melanoma, kidney, and other organs. With secondary testicular cancer, the prognosis is poor and treatment depends on the type of primary cancer. Risk factors for testicular cancer include men with undescended testes, family history, race and ethnicity. White males have a higher rate than other males, and more than double the risk of Asian American men. Occupational hazards such as mining, oil and gas production, leather procession are also risk factors. Assessing for testicular cancer, signs appear gradually with a mass or lump and are generally painless enlargement of the testes. Patients may complain of heaviness in the scrotum, inguinal area, or lower abdomen, and may also have backache, abdominal pain, weight loss, general weakness, and it tends to metastasize early. Diagnostic tests include monthly self-exams, tumor markers, beta-HCG tests, alpha-beta protein tumor markers, ultrasound, CT, and MRI. Treatment depends on the type of cell and extent of the disease. Orchiectomy, which is removal of one or both the testes, chemo, radiation, or a combination of all of these therapies. Surgery is the main treatment of testicular cancer. Erectile dysfunction, also known as impotence, is very common, with 25 to 50% of men over 65 suffering from this condition. ED can be separated into two types. There's organic ED and there is functional ED. Organic ED is the gradual deterioration of function caused by a disease process. Some disease processes that can cause this include diabetes, vascular disease such as chronic hypertension, pituitary tumors, and testosterone deficiency. Functional ED is caused by anxiety, fatigue, depression, and pressure to perform sexually. When assessing patients for ED, the physician or healthcare provider must determine if it is an organic cause or a functional cause. To do this, you're going to want to do hormone testing and collect a sexual history and assess use of medications and alcohol or drugs. ED can be treated with medications such as sildenafil, which is Viagra, Levitra, and Cialis. You want to instruct patients to take the medication 1 hour before sexual activity. Avoid alcohol while on this medication because it may impair the effects and ability to achieve an erection. Patients on nitrates should avoid taking any of these medications due to severe hypotension and decreased blood flow to vital organs. So before you administer nitroglycerin to anyone, be sure to ask if they have recently taken any ED medications such as Viagra or Cialis. Other methods for managing ED include vacuum devices, which involves putting a cylinder over the penis and using a pump, which creates a vacuum to draw blood into the penis to maintain an erection. Patients can also receive a penile prosthesis. There are semi-rigid options or inflatable options. Semi-rigid results in permanent erections, while inflatable options involve placement of 2 cylinders and a saline reservoir that use a pump to move saline from the reservoir to the penile cylinders, causing an erection. Some reminders from Module 1 or topics that you would want to be familiar with. Be sure you know your lab values associated with the renal and urinary system and what you expect those lab values to be for the different disease processes. For instance, for a patient with chronic kidney disease, what would you expect the potassium to do? Or what would you expect their ABG to look like? Be familiar with the different types of dialysis, organ transplantation, BPH, prostate cancer, and erectile dysfunction.